table of repeated real. It may be worth explaining that voting members, including health partners, are in attendance in the chamber to take part in the debate and to make decisions. Some officers and partners may be joining the meeting via Microsoft Teams. Are there any members in attendance as substitutes today? Do any members wish to declare any interest in relation to any matters included on the agenda? We have no Part 2 items today, so the press and public won't be excluded. Does the board agree to approve the minutes of the meeting on the 16th December 2025 as the correct record? Yeah. Firstly, I would like to welcome Ian Smith to his first meeting of Brighton and Hove Health and Wellbeing Board. Ian is the new chair of the Combined Surrey and Sussex Integrated Care Board, and we are really glad that he has found the time to join us today. Thank you. We have several reports to consider today. Our first report is the annual report of the learning from lives and deaths of people with a learning disability and autistic people review. LEADER. LEADER has been operating since 2017, collating information on some of our most vulnerable citizens. It is essential reading for everyone delivering services in the city. We also have a report on neighborhood health. This is an area of increasing focus, and we are waiting for statutory guidance, which is expecting to give health and well-being boards significant new duties to champion neighborhood health. We also have a Better Care Fund report today. This provides an update on Q3 performance and outlines what is in the latest Better Care Fund planning guidance. In addition, there is a verbal update from NHS Sussex on the latest changes to NHS commissioning. I also want to remind members that we have a health and well-being development workshop on March the 12th. All board members have been invited to this, and I would like to see as many people as possible attending. The workshop will be led by Joe Webster and Steve Betzer, who are working with the local government association. We have managed to get the local government association to support health and well-being development, and some of you may have already spoken with them to help them get a sense of where the board is and what improvement steps we need to take. I attended the Sussex Health and Care Assembly meeting on the 23rd of February. This was, as usual, an interesting meeting. I would like to mention some highlights. The presentation by one of the East Sussex PCN teams of how their day looks like as an integrated healthcare hub. It was very interesting to hear about how the multidisciplinary teams work together and the connection between clinical health and community health and well-being teams. The questions raised provided some very good insights. For example, the question about the type of measurement used by ICT to measure improvement in vulnerable groups like the neurodivergent, disabled, ethnic minorities, LGBTQ, and economically deprived. In relation to this question, the support role of housing and educational institutions with data was highlighted. Changes facing the SPFT with regards to mental health was on the table, and rightly so. It was disclosed that the numbers and complexity of cases were on the rise. But it was encouraged to learn that work is going on to provide the appropriate wraparound support for those feeling suicidal and in crisis. Having one of the highest cases of suicidal deaths nationally, averaged at 32 deaths per year, we will be watching this progress closely. Also mentioned were the ongoing reforms to align community mental health and well-being teams with the ICB, which was most welcome. It is worth mentioning that the initiative has already been established in Brighton and Hove. Finally, we are currently in Ramadan. I will call a short break to the meeting between 5:45 and 6 p.m. to allow anyone who is observing Ramadan to break their fast. I'll call now to the Democratic Service Officer for the call out of the items.
Thank you. We have 3 substantive reports to be called this evening. So item 38 is Learning from the Lives and Deaths of People with a Learning Disability and Autistic People Annual Report. Is anyone going to call that? Yeah. Item 39 is Introduction to Neighbourhood Health Agenda for Change. And item 40 is Better Care Fund. Thanks. So items 38, 39 and 40 have been called for discussion.
We have one public question today from Gary Villa. Mr. Villa, would you like to ask your question, please?
And it's Gary Vallier.
Sorry.
That's okay. Just for the record. Okay, ready? In light of the final caste review and the Supreme Court's clarification of the Equality Act in 4 Women Scotland versus Scottish ministers, and the High Court's confirmation of the lawfulness of the interim guidance issued by the Equality and Human Rights Commission, and the DfE's draft 2025 update to keeping children safe in education, will the board confirm what steps it has taken or will now take to ensure that the local safeguarding strategy, mental health pathways and partnership guidance across Brighton and Hove are aligned with this clarified legal and clinical framework?
Thank you for your question. Brighton and Hove Health and Wellbeing Board brings together key local leaders to improve the health and well-being of the population of Brighton and Hove and reduce health inequalities through developing a shared understanding of the health and well-being needs of its communities from pre-birth to end of life, including the health inequalities within and between communities. Developing a shared focus on the most vulnerable local residents, including Black and racially minoritized communities, people with disabilities, LGBTQ communities, people experiencing mental health problems, and older people, and provide system leadership to secure collaboration to meet these needs. The board has a role in strategic influence over commissioning decisions across health, public health, and social care, encouraging integration where appropriate. Recognizing the impact of the wider determinant of health on health and well-being, and involving patient and service user representative and councillors in commissioning decisions. Matters relating to education in the city are not within the remit of this board. All scrutiny and decisions made by the board fully take into account and are properly informed and guided by the law and government guidance relevant to the matter under consideration. The board expects partner organizations represented on the board to ensure policy, commissioning, and delivery of services to be compliant with the applicable law, statutory guidance when it is eventually published, and to be guided by and fully take into account relevant non-statutory guidance and codes of practice. This includes recent case law pertaining to the Equality Act 2010 and any future guidance and code of practice issued as a result of that case law. The case to which your question specifically refers concerned workplace regulations and highlighted the need for all public agencies to adopt a sophisticated approach to the provision of service. To quote the judge, each set of statutory provisions considered in the interim update provides a floor for provision of facilities, but neither provides a ceiling. The case you refer to also reminds agencies that laws and guidance cannot seek to regulate every possibility that can arise day to day, and in the circumstances that are too numerous to anticipate. This board would endorse the view expressed by Mr. Justice Swift that those who provide facilities, whether to the public or to their employee, should comply with the law, but also be guided by common sense and benevolence. Do you have a supplementary question, please?
Yes, I do, if I may. And it will take me 31 seconds to read it. In his deputation to the board last September, a parent stated, and I quote, "This is not safeguarding, it is ideology overriding evidence, clinical caution and parental responsibility." The board did not provide a substantive response to that allegation at the time. Given the publication of the cash review and its clear statement that social transition is not a neutral act, does the board accept that where a parent alleges harm linked to local gender identity practice, safeguarding governance requires active examination rather than silence in order to avoid the appearance of predetermined policy positions? It seems the board chooses silence. And that's my supplementary. Thank you very much.
Thank you for your question, Leah. Pardon? Immediately.
Sorry.
Written, yes. Yeah, written. Yes, thank you. Thank you for your question. You will be provided with a written response to this question. The response will be included in the minutes of this meeting. We have no member questions today, so I would like to invite Tanya Brown-Griffith and Dr. Adam Fazekule to introduce this item. Item number 38, learning from the lives and deaths of people with a learning disability and autistic people.
Chair, do we have permission to
I think
as members, would you prefer us coming?
Yeah.
Yes.
Oops. Right, so I will start off by summarising the LEADER paper. I think the board will note that the LEADER report comes to the board annually, and as stated in your update, Chair, since 2016, this sort of learning from the lives and death of people with learning disabilities and autistic characteristics has been part of the provision within the city, but obviously wider across the national footprint. I think the report that I want to sort of highlight for this year in terms of the notification of the death headline finding from this particular report shows that there were 158 deaths noted in Sussex between 2024-2025 period, continuing a year-on-year, obviously monitoring, but it's also a year-on-year increase. One, I think I'd like to draw to the board, this is because we have improved reporting and there's also improved reviewing and the in-depth review that's carried out through the learning from deaths of people with learning disabilities and autistic persons, which is a LEADER program. It's a national program and it's to identify avoidable causes of death and to ensure that we put proper service improvements in place, but that we're implementing the learning from this review into practice, clinical practice, but also into policies and procedures. So noting the report, continuing key headlines, the median age of death is 62, and obviously reinforcing there is a scale of inequality that still exists in terms of there is about a 20-year gap between those who are dying who have learning difficulties, disabilities, or are autistic. And therefore, there is something else we need to do and more we need to do in the city, but also wider. The leading causes of death remain consistent with previous years: respiratory disease, circulatory disease, CVD, cardiovascular disease, cancer, sepsis, frailty, and multimorbidity. And those remain the same year on year. We have seen a slight improvement in the number of focused reviews that we're carrying out in Sussex. So we have about 41% were focus reviews, exceeding the national target, which is 35%. But we're still under our own ambition, which is 100% of all reviews to be completed within a 6-month period. So in one extent, we're improving, but in another, we need to do much more. We are obviously ensuring that the key themes are being cascaded, and some of those include lots of sort of deeper examination that we need to look into, includes epilepsy, obesity, screening, non-attendance, autism without learning disability, safeguarding, and those that are in out-of-area placements. Those are particular hotspots for us that we want to allow deeper reviews into those high-risk themes. So learning themes, so key learning themes from this year's report includes diagnostic overshadowing. And I've got a very experienced clinician beside me should there be any clinical questions that come up, in terms of just ensuring that we're including a delayed recognition of deterioration. So that's a common theme throughout all the reviews that were carried out in this year. So delayed recognition of deterioration, missed opportunities for screening, as I mentioned before, the death rate difference between somebody without a learning disability and somebody with a disability is 20-year, and therefore what we want to ensure is that we're applying the same opportunity and increasing the opportunity when it relates to screening, notably breast screening particularly, but also in terms of annual health checks, and ensuring that every opportunity, so when we talk about ensuring every opportunity is maximized, but also in terms of every contact counts. Sepsis recognition and escalation, I was just discussing with our clinical lead here around ensuring that's cascaded, because I think there are obviously really good early warning sign guidance around sepsis recognition and escalating that, and obviously something we need to do much better in community settings and in care home settings particularly, and that's shown up through the learning from this year's report. I think in terms of mental health, we noted within the learning this year that there are several barriers that remain for persons with autistic characteristics without learning disabilities, particularly around mental health and high suicide risk. So this is something that needs to be better cascaded, and ensuring that the early warning signs again are being monitored and managed within our clinical care and our service delivery. So what has changed as a result is that we have now had widespread rollout of the Stop Look Care training to improve early identification, and I mentioned that there is a sort of a process to follow through to identify deterioration in care, but also in care settings, so care homes and nursing homes. We have been working with all our service providers around targeted work for screening, particularly looking at cancer screening, working with the Cancer Alliance, particularly in terms of ensuring that the service is very accessible to those with learning difficulties, disabilities, and characteristics of autism. We have integrated a LEADER program within safeguarding, suicide prevention, palliative care, and preventative programs, and that's been seen through some of the ICT or integrated community teams' ways of working. But also we need to ensure we have stronger co-production with people with lived experience. That is an area that we're not doing as well as we'd want to do. We do have a lived experience group that works with our LEADER program, but I think what they've said is that this breadth and spread across that demographic is not as we'd want it to be. We'd want to see a better spread in terms of those from ethnically diverse backgrounds, but also younger persons being part of that lived experience group and program. So I think in terms of forward priorities, which is why this paper has come to the board, is to ensure that each organisation represented here at the Health and Wellbeing Board has a process, a structured process of cascading the learning within the organisation to frontline staff, and that it doesn't sit at an operational management level, but it really gets cascaded into clinical practice, and it becomes part of embedding of how we deliver services. And we're recognising the inequalities that persons with these characteristics and challenges face. It is obviously one of the key focus of the board to address inequalities and to ensure all of our work programmes that come through this board evidence that we're addressing that inequality. I'll just hand over to my colleague Adam in case you want to add anything.
No, I don't have too much to add. It's a great report, and the more information we can get, the better moving forward. I think it's all about what actions we can take from this report moving into our various organisations. I think I'll be taking this directly to primary care, definitely the screening and the complexity around recognising when someone's severely unwell. These are things that GPs and doctors on the front line can definitely make a big difference on. In terms of the 20-year gap, that's a really complex issue that's going to require all of us to try and address as a society. So, yeah, great.
Thank you, Chair. Back to you.
Thank you, Tanya and Adam, for your presentation and for the work you're busy doing. Do we have any questions or comments?
Hi, thank you. Excuse me if I've got this, or not got this. I'm just back from leave, so I have read the report very quickly. But I just wanted to ask about the Oliver McGowan training, which I believe is now mandatory for all NHS staff and care staff. But I understand even though it's mandatory, there's still quite a slow take-up, and if that is being encouraged.
I'll start and Adam will come in. So I can absolutely say it's mandatory training, and certainly even for ICB staff that are non-clinical facing, it's one of the mandatory training and has been completed. I think we're at 95% completion of that training last checked. So there's still a few gaps, but we're improving.
Yeah, I was just going to say it's something we're discussing because there's a whole day training, and then there's smaller sort of 1-2 hour training, and the big debate is what primary care is going to do across the city.
Any more? Yes, Councillor. Jose.
Thank you, Chair. I was just wondering what the criteria for inclusion in this report is, because obviously you've got autistic people that have got learning disabilities, autistic people that don't have learning disabilities. I wonder how have they been sort of separated in this report, or are they all included in this report? How has that been organised? Thank you.
Thank you. So all included in the report, but the report does separate the two when there are characteristics or depth that are different. So it does separate autistic people with learning difficulties from autistic people without learning difficulties, but both sets are included in the report.
Thank you, Chair. Alan Boyd, Health Watch, Brighton and Hove, and thank you for the presentation. I think the report's really quite thorough, and I think it shows some really good learning, so I think that's a really good positive sign. I had a particular question around the annual health checks. So last year's annual reports said that Brighton and Hove were achieving 70.5% of people with learning disability on GP registers receiving their annual health checks. I just wondered what the target was this year and whether there's been any improvement on that. And related to that, do we know how many GPs in the city now have the thumbs up kite mark, which is the accreditation, I think, for GPs who are working? I'm not quite sure what the kite mark relates to, but there was 5 last year. I just wondered whether that's been an improvement. And I was also just curious as to how much we're engaging with people with learning disabilities and autism, and whether we're hearing from them enough. You've referenced that already, and I saw that the person who was on the leader group as the lay member stood down. So I just wondered what more we need to do to hear those people, because 1 in 4 people who aren't having their annual health checks is too many, and it seems to have been a stat which is sort of frozen for some time. And I just wonder what we as a health and wellbeing board and as partners can do to do more around this, and is it about engaging with people and understanding more about what those barriers are? Do we understand them enough? And I saw the reference to the NHSE pilot, so maybe that's going to tell us some more, give us more information. But yeah, those are my questions. Thank you.
I'll say something quickly. So NHS health checks, we know are good, but we know the people who access them are generally the people who are very conscious about their health and not always the most sort of socially deprived or have any or another characteristic. So the whole move of integrated community teams is trying to bring these checks to communities, and that's what we're trying to do in the east with the Health Hub and in the west with working with Hangleton and Knoll. So that is a journey we're definitely heading towards, but yeah, it's difficult.
Just to follow up on your other questions, Alan, I think there is a lot more we can do to build in the lived experience of those with learning difficulties and autism characteristics. And the whole sort of neurodiversity lived experience is really important and key. And I think an area we can do that more is the neighbourhood health teams and the community teams around this, because a core part of the delivery of neighbourhood health, which is one of the items we'll take to you this afternoon, is about integrated care and focusing on those hyper-local communities, particularly those communities that are faced with significant disparities, and including the communities we reference here today. I think the other thing of note is that since the introduction of LEADER, so LEADER is a national programme, but we note that since the introduction of LEADER, there has been a decline in avoidable deaths for people, but we need to do more. So it's doing something, but what we need to do within the neighbourhood teams and within neighbourhood health hubs or integrated neighbourhood hubs when they're present is to ensure we're absolutely focusing outreach target to those communities and the health checks as well around that. So it's an area to improve. In terms of improvement, I don't think we've improved much this year on last year's numbers for health checks. So I think the neighbourhood health model will offer us an ability to in-reach a little bit more.
Just very quickly, do we think we understand the barriers, or do we actually think there's more work to be done to actually understand those barriers first before we can implement changes?
Thanks, Alan. I think we understand the structural barriers, But in terms of the personal barriers for individuals, we could go a long way further. And I think part of the commissioning for this year is around community engagement. And obviously yourselves as Health Watch do a lot of that, building the people voice and ensuring that voice of communities is reflected in service delivery. And we need to do more. And that's why in our commission intentions, we're very clear we want to be able to engage more, co-produce more with communities.
Any questions or comments? No? I just have one question myself. I understand about check-up, I mean, continuation to your question, the big question, why one, 1 out of 4 people who come for checkups. I understand that Hangleton and Knoll project did some, research work with the group of multicultural women concerning breast cancer checkups. I wonder what the results were. What were the barriers found which prevents, turn up? Do you have any information on that?
I'm not particularly clear on the results around that breast screening for women from multicultural backgrounds specifically, but I know that the Hangleton and Knoll project, as well as the East Brighton Health Hub, are really focusing on areas of greatest deprivation and diverse communities. I think screening, generally cervical and breast screening, were very well below the expectation in the city, and the Action for Cancer, which is a VCSE-led provision, is around bringing those communities into screening and improving access. And those two organisations is the Hangleton and Knoll project, as well as TVC, which is sort of bringing together VCSE voice into improving screening for persons from ethnically diverse or deprived communities. But I don't know the specific outcome of the Hangleton and Knoll actually project. But we could certainly go back and check it and return to the board with an update.
I'm just wondering whether, some data like this, which is very important, and it's a lot of work went into it, and it happened quite, if I remember, it was last year or the year before, we are not making use of the data making useful, implementation of the data, because I would have expected now that is one of the data which you have and you're using for the improvements. So maybe there's a gap which we have to find solution for. Yes.
From my memory, a lot of it is geographical. So the Park Centre for Breast Screening is quite a long way away from Hangleton Knoll, and it's traditionally quite separate from it. So quite a lot of it's practical. A lot of it is trust and relational, and that sort of sits across all the inequalities we see. There is less trust of the health system in general, and that's something we definitely need to work on improving. But those are 2 that I remember. There'll be more that we need to go through.
Thank you. Any more questions? Comments? All right. So do members agree the recommendations? That the board notes the information provided in this report, and that the board approves the organizations represented on the board utilizing the learning from leader and developing formal internal cascade processes in order to impact on the reduction of the mortality gap for people with a learning disability and autistic people. Yeah, okay, thank you. Now we'll go to item 39, Introduction to Neighborhood Health Agenda for Change. I'd like to invite Steve Hove to introduce his co-presenters and to introduce the report, please.
Thank you, Chair. For board members, before I take us through this item, I'd like to introduce my colleagues who will be co-presenting this item with me. So I'd first of all like to introduce Tanya Brown-Griffiths. Tanya is the Director of Joint Commissioning in the Integrated Care Board, and Tanya will co-present the presentation with me, which will go through the kind of context of the National Neighbourhood Health Programme. It will go through the implications locally for Brighton and Hove and the city, and it will also go through the implications for the changes in health and wellbeing boards, so very relevant to today. I will then hand over to my colleagues who are also here today. I'd like to introduce Kate Pilcher. Kate is the Chief Operating Officer for Sussex Community Foundation Trust, and Dr. Colin Hicks, who is the Deputy CEO and Chief Strategy Officer for Sussex Partnership Foundation Trust. After Tanya and I have presented the sort of national context and the local context, Kate and Colin will take the board through the Neighbourhood Alliance and the implications of the Neighbourhood Alliance and how that will help drive forward part of the governance and delivery around neighbourhood health. So I'm first of all going to go into the presentation, and before we start I'd like to invite Tanya to do the first couple of slides. Thanks, Tanya.
Thanks, Steve. So I think I will just set the context to the National Health Programme around neighbourhood health and why that programme is, as it is today, really a cornerstone to the delivery of the government's 3 left shift, which is going to be bringing care closer to home and obviously closer to communities, ensuring that we are moving to prevention and treating persons at the point of where they are in their communities where possible, and ensuring that obviously acute access is appropriate and not avoidable, and ensuring that we're tackling health inequalities and again building care around communities and ensuring that all that we do is in an integrated way, making very good use of very limited resource and ensuring our pathways are not duplicate and that we're not creating unnecessary complexity, which we know exists in many of our services now. So I think in terms of the national reform around neighbourhood health is there because we have to tackle the rising levels of multiple long-term conditions, greater complexity in those conditions in terms of interrelated interfacing factors. And we know that many of our services and many of our commissioning is fragmented and often very much around a hospital acute centric focus. So it's a big shift for us, and we know we cannot continue that, both in terms of funding, but also it's not what our communities, it's not what people are saying they want in terms of the insights that nationally has driven the neighbourhood health reform. We also know that in terms of experience, people are experiencing lots of delays, duplication, siloed working, and obviously neighbourhood health is one of the intended programmes to improve that provision. And obviously the government's prioritisation is very much strong around this being a core pillar within the 10-year plan. So of note, it's a really important reform and a really good integrated piece of work between communities, the VCC sector, all of our NHS providers, and our local authority, and bringing all of that provision into a good package for our communities. So NHS Sussex has developed, obviously, listened to the national mantra, and very quickly, we were one of only 5 ICBs at the time to develop a really framework around neighbourhood health. Started out as being a draft framework, but obviously moved quite quickly into being a sort of a framework around how we drive the model for neighbourhood health. We wanted to build a neighbourhood health framework around the core components of the neighbourhood health model, which includes population health management, and colleagues around the table will recall that in 2021 we rolled out the National Population Health Management Programme in Sussex. So part of that was being data-driven, data-focused, and including that we know where inequalities lie. The other section, other components of the 6 components for neighbourhood health is modern general practice, standardised community health services a third, neighbourhood MDTs or multidisciplinary teams is a fourth, integrated community and intermediate care is the fifth, and the last is urgent neighbourhood health service. So those services are cornerstones, so key foundation of the neighbourhood health model. And so the ICB's role in terms of strategically commissioning is maintaining that system enablers. So we want to ensure that we're including risk stratification or a way of identifying cohorts of communities and population who we need to tackle. And there's a pyramid that has been shared with the board previously, but can also be shared after today if members would like to see that, looking at population based on high, ongoing, or whole population needs. So it's a sort of a need-based way of commissioning services. We co-produced and published the NHS Sussex Commission Intentions 26-27, and I think most partners here would have been in the room last October to bring together a lot of the thoughts and comments within that Commissioning Intentions, which is then finalised and published. We've issued Commissioning Intentions letter to all of our providers to ensure that the focus is on care closer to home or neighbourhood health, and ensuring that we're aligning services where possible, as many as possible, around that delivery. And lastly, I'll just say that the ICB's sort of clear expectation is that we will reduce avoidable emergency admissions starting this year with the over 65s, but that we will also want to ensure that we're increasing uptakes of screening and preventative, such as the health checks we mentioned earlier. So we've put some targets around those 2 areas, so avoidable admissions and screening and vaccination uptake. So I'll stop there and hand back to Steve.
Thank you, Tanya. So Tanya's really talked about the national context of neighbourhood health and really focusing on delivering care and well-being to the health of the nation in the communities and moving away from an acute hospital-centric model. And so what does this mean for the city, and what does this mean for Brighton and Hove? And our sort of delivery vehicle for neighbourhood health is really focused around our integrated community teams. Brighton and Hove as a city is established as a single integrated community team across the other 12 in Sussex. But within the city, we have 4 key kind of delivery partnerships. So we have a West area ICT delivery partnership that is focused around the west of the city from Portslade through to Central Hove. We have a central ICT partnership, and then we have an East partnership. So we have 3 kind of geographically based ICT delivery groups. And then because of the particular population we have in the city, around our single homeless population, and also around our community with multiple compound needs, we have a kind of a city-wide integrated community team that serves the needs of that community right across the city. So what the diagram is showing you on the slide is that sort of breakdown of those 3 teams with that single team. We've really tried to focus some of the leadership around our ICT partnership groups through our vibrant voluntary community and social enterprise sector. So the Hangleton and Knoll project has provided a locus and some of the leadership around our West ICT, and the Trust for Developing Communities has focused some of that support through the East. As Tanya talked about, one of the key elements of moving into neighbourhood health is making sure that it's data driven and we have good levels of data. I think at the last Health and Wellbeing Board, our colleagues in Public Health took us through a fairly detailed run through our health inequalities data and our health count data. And so we're quite proud in the city of the level of data collection we have, and we're very data driven, and we have good data both in terms of our population health as a whole city, but also our population health in terms of health inequalities. And we are developing and have developed an integrated community team dashboard that will help frame our performance in this new world of neighbourhood health going forward. Our ICT leadership groups are leading a partnership health inequalities programme across our 3 ICTs. Moving on to the next slide. So I guess what's coming with a shift into communities and into neighbourhood health through the 10-year NHS plan, but also through some of the other key things that are happening across the nation, things like devolution and the local government reorganisation that will fall out of that. What's emerging from all of those kind of seismic changes is that the emerging national guidance is clearly stating that health and wellbeing boards will have much more local accountability for neighbourhood health and be expected to have place-based neighbourhood health plans. So health and wellbeing boards will remain accountable for the Better Care Fund, and I think we're hearing about our Q3 Better Care Fund performance in a moment. We are also refreshing our local health and care partnership governance that supports our health and wellbeing board to support neighbourhood health and our ways of working. So we have a range of forums that we attend across the health and care system. I think some of the changes nationally around integrated care boards are facilitating some of those changes, and we also need to respond to the requirements of the neighbourhood health. And our local integrated care team plans will really provide the basis for developing a refreshed health and wellbeing board plan for the city. So again, we've got our health and wellbeing board development sessions set up. We would urge all of us who are members to attend those, and that will be part of the way that we are building new relationships. So it's really clear, I think, that the health and wellbeing board is going to become a much more visible and accountable vehicle for managing the delivery of neighbourhood health, and we will all have a part to play in that. The other essential kind of mechanism and vehicle that's new for delivering neighbourhood health is the new Neighbourhood Health Alliance. We have a Sussex Neighbourhood Health Alliance and Sussex Community Foundation Trust are the chief kind of contractor around that alliance. I'm going to stop talking more about the alliance because I lack the technical skills to do that. And so I'm going to hand over to Kate and Colin, who will take us through the main elements of our Neighbourhood Health Alliance. Thanks.
Thanks, Steve. So I'm going to start just by talking a little bit about how the Neighbourhood Alliance is being set up, and Colin will then talk a little bit about how mental health is working together with physical health in that space as well. So I think the paper describes that the Neighbourhood Alliance isn't a single formal entity. It's made up of Sussex Community NHS Trust, as Steve said, as the lead contract holder for the Alliance, East Sussex Health Trust, Sussex Partnership Trust, and the Sussex Primary Care Collaborative. So we're all working together to form an alliance to deliver the neighbourhood health requirements. As part of that alliance, we are working up currently a memorandum of understanding with our local authority colleagues, with the Hospice Alliance, and with the voluntary sector. So we will all collectively come together to deliver on the plan. Steve's already talked about the 15 integrated neighbourhood teams and how many of those are based in Brighton and Hove. And I just wanted to kind of touch on a bit more on what Tanya said around what we've actually been commissioned to deliver. So preventative and proactive care for high need populations, the ICT-led targeted interventions, and what that will mean is that we've got some overarching commissioning intentions that we need to deliver on, and we will collectively deliver on those across Sussex. But each ICT will be able to look at the specific needs of its local population and decide on a targeted offer, which will differ between each ICT potentially in order to meet the needs of their population. For all of the ICTs, we do have to deliver a 10% reduction in avoidable emergency admissions, and we need to achieve a 15% increase in uptake of vaccinations and screening in underserved communities. And we're also working over the next year to look at how we work much more closely with our children and young people's services, including our local authority services, to look at what the integrated neighbourhood health offer will be for children and young people, and how we work in a more targeted way to achieve the best outcomes for children and young people. We've recently set up a Neighbourhood Alliance board that is chaired by the CEO of Sussex Community Trust and includes all of the partners that I've referenced earlier in terms of representation. And that board will be responsible for supporting all of the ICT teams. We're currently delivering, as Tanya's referenced, some organisational development support to them. They're doing a lot of work locally with all the partners that I've referenced to look at how we really transform the way we deliver care for people in our communities in a much more joined up way, and establishing different relationships in terms of doing that. And the final thing I guess I just wanted to say was that the Neighbourhood Alliance board will then have the place-based delivery groups that have been operating for a couple of years, I think now, haven't they? So those will be the delivery mechanism by which we deliver at a place-based level, and they will report into the Neighbourhood Alliance board. The Neighbourhood Alliance board will form part of the ongoing governance arrangements that Steve just talked about in terms of the role of the Health and Wellbeing board. I'm just going to bring Colin in to talk about mental health, and then very happy to answer any questions.
Thanks, Kate. Yeah, I guess probably the bit to add from my sort of perspective is, so one of the things that we're really keen to do is to try to start to get rid of this siloed approach where mental health sits in one hand, physical health sits in the other hand, but yet it's the same person in the middle. So as we will have heard before, we looked to develop a neighbourhood mental health team model that completely aligns with the same ICT footprint. So for Brighton, again, we've redesigned our services so that we will have the three services covering sort of 3 different geographical areas. And we've looked to bring together a range of different community mental health services that were already in existence, both provided by SPFT, but really importantly also some of the voluntary sector provision that we have within the city as well, so that we're offering a much more kind of integrated, holistic offer itself. Within that, what we've now made sure is that as we've got the ICT leadership groups developing in each of the 15 areas across the county, mental health is represented in absolutely every single one of those leadership groups. And I think what's really important is that recognition that for all of our staff, we're trying to move forward to thinking about a population, not just a waiting list, and the whole person rather than just kind of sort of fragments of the individual. The neighbourhood mental health teams, or NMHTs, which as I said kind of co-align with the ICTs, have a similar set of expectations in terms of delivery over the course of the next 12 months. So for us, one of our key focuses is around decreasing the number of people presenting in the A&E department. So how do we support them in the community, early identification around deterioration, and looking at alternative access points for support rather than A&E being kind of sort of the default, as well as really focusing and thinking around kind of sort of waiting times particularly as well, and thinking about actually what does that kind of sort of speed of access look like. But also, if you've got an individual who's operating across multiple teams between ourselves, SCFT, etc., actually how are we trying to think about every contact counts, how are we trying to reduce the frequency of visits from healthcare professionals so that we're really maximising the input that we have. I think one of the big advantages that we've got now is that SPFT and our voluntary sector partners in February transitioned onto a new electronic patient record. And thankfully, it's System 1, which makes our life a lot easier in terms of relationships with lots of the GP practices, but also Sussex Community Foundation Trust, because we're able to use one electronic system and start to be able to sort of see the individual patient across the multiple organisations. I guess the last point just to sort of leave on, and it slightly overlaps with the conversation we were having around LD health checks. We know that we have a similar mortality gap for people with severe mental illness, 15 to 20 years mortality gap. And so one of the key focuses around the development of the neighbourhood mental health teams, and I guess why we're particularly interested in kind of coming to the table to think about this joined up way of working, is that we also need to see similar improvements in terms of things like the physical health checks for people with SMI, but also really importantly, what does that then lead on to in terms of changes, in terms of kind of accessing healthcare sort of thereafter as well. So I think it's unique. I think there are some challenges, but I think, having the sort of 4 partners around the table really kind of working together with a single set of objectives is really positive. Thank you.
Okay, thank you all for your presentations. And I think this news is very welcoming, having, mental health within each ICT. And that is very helpful. I will welcome questions now. Yes, please.
Yeah, I think as Tanya said at the start, this isn't a nice to have actually, but we're not going to survive as a health and care system unless we really push hard on this neighbourhood health. It's unsustainable, the current trajectory. It's not going to be easy. And I think there are at least 2 major challenges. I think the first is redesigning pathways that take activity out of the acute hospitals. That can take a very long time. We have tried it in parts of the country and in other countries, and we can't underestimate how difficult that is going to be. I think we need to prioritise the pathways that we are going to work on at the start. I think too many initiatives will be the death of the neighbourhood programme, so focusing on the main high burden care pathways, frailty, diabetes, COPD, they'd be pretty high on the list. And we've got to improve the health of the population because it is deteriorating. Life expectancy declining, infant mortality in the poorest 10% of our population increasing, which is a disgrace for this country. And take the pressure off the major NHS pressure points, ambulance call-outs, front and back door of hospitals, waiting lists and GP practices. Because not only are those expensive to the system and divert money that we should be applying to prevention, but they are also, if patients or residents arrive at those places unnecessarily, then frankly it damages their health even more. So I think that's the first big challenge, and it's not easy because hospital doctors find it quite difficult to, and they've been trained to operate within a hospital and not in a community context, and it can take 3 or 4 years, even for people like geriatricians, to really change the way they practice. So this is really hard work. I think the second part is population health. We've got to shift from a crisis-driven system to a system that identifies the causes of harm and the drivers of cost and begin to address those rather than run around trying to hit targets that are the symptoms of a system that's failing. And I think that is what I call a high-risk care management. So that is identifying the most at-risk people in our population. Colin, we talked about it last week, and really focusing multidisciplinary teams. A lot of important role for GPs, I think, in curating the care plans for these people, but the management of those care pathways have to be continuous for the most vulnerable in our society, and they have to be MDTs. So mental health, which I know Colin's up for, community, social care is a key part of this. We can't have the fragmentation that has damaged our system in the past. I think, as you said, the Health and Wellbeing Board is going to become increasingly important in this, because that integrated pathway that I talk about, this is about the people around this table. It's not just the medics, it's not just the hospital doctors, it's not just the GPs. Everybody has a role to play here. Housing is becoming an increasingly difficult issue, especially for mental health discharges from hospitals. So, and we've really got to demonstrate impact. I think one of the problems of prevention is that we all know prevention as a general concept is good, and we'd all sign up to it because we know how bad it is when people get into crisis. But actually, when you start looking at individual programs on prevention, it's often difficult to really be sure that they are having impact. So we really need to have measures that not only take the pressure off those points that I've talked about. I'd like to see targets like halving the number of A&E attendances, taking medically fit for discharge down to 0. I mean, I think we've really got to move the dial on this. But also, and most importantly, on the health and well-being of our population. So I think the Health and Wellbeing Board is really crucial in this, and we cannot fail, frankly, because the current trajectory is appalling and pretty disgraceful for us to have allowed it to get to this state.
Thank you, Ian. Any more comments, questions?
No.
Thank you, Chair. Tom Lambert here. I'm one of the voluntary sector reps, and in my day job I work for the Carer Centre for Brighton and Hove. A couple of comments and a couple of questions, if I may. First off, I'd like to place on record our sector colleagues' appreciation of the level of involvement that the voluntary sector has had so far in the development of the neighbourhood health teams. But I also would point out that many, if not all of those sector partners are doing so without any additional resourcing. And I suppose I just want to place on record also a recognition that many of us are delivering citywide services, and where we possibly can, we will try to join leaders in delivering at a local neighbourhood level. But there, as Steve mentioned with the multiple compound needs team, for example, there will remain communities of interest that benefit from citywide delivery. I just wanted to keep that on the table. My questions are whether there's anything within the model that any of the speakers can identify that specifically support those people who are in full-time or part-time work, so any provisions that are likely to be offered on a regular basis outside of perhaps normal office hours. And I think it's quite clear the benefits of going out to people locally in terms of early identification. But my second question is about what are some of the specific benefits to those who have, as is cited in 1.7 of the report, previously identified long-term conditions. So provisions for working people and those with long-term conditions.
Should I start? And then will certainly be something that the Alliance will be able to pick up. So in terms of the Commission intentions and in terms of the neighbourhood health model, there are no community that is outside of the scope, to put it in a better way. It might mean that we start with certain high-risk population groups, but that's starting with, that's not the end of the neighbourhood health model. And working age groups are not excluded at all in the provision. We're starting with those with multiple long-term conditions and or frailty factors, or those that are going in and out of acute and or emergency services frequently. And that does include many people who are working whether part-time or full-time with multiple long-term conditions or other multiple compound needs, as Steve mentioned earlier. So I think in terms of the provision is developing, and it's certainly something the Alliance will be monitoring, starting with the high-risk group, but we will be moving to ongoing and the whole population. The prevention offer is for whole population, so that includes working groups and also persons who would want to return to working, and we run a Work Well pilot, as you know, Tom, in the East Brighton area. That's again supporting persons with either chronic pain or musculoskeletal conditions and mental health that are keeping people away from work, and we want to improve the access back into work. So I think in terms of provision, in answer to your question, there is no limitation to the provision, but it's something in terms of what we want to do with the Commission in this year is to get further insights from people as to where the gaps are. And that's why we're commissioning some of the community engagement, co-production piece from the voluntary sector, because you have the eyes and ears and the trust of those local communities and can improve the care for those local communities. And part of that is if we don't have enough provision for those with working age offer, then obviously we'd want to hear about it. Steve?
Thanks, Tanya. I mean, I think you've covered a lot of it. I mean, I think, Tom, that we are well engaged with the VCSE, and we recognise that our VSE partners in the city can often be more flexible and responsive than statutory services. So I think we will keep that conversation ongoing. I think we're at the start of this process, and I think there's a dilemma that we've got to grapple with as a health and care system, whereby there clearly needs to be a mechanism to move some transformation funding out of acute care into the community, because if there's a higher expectation in the community, there's got to be some resourcing. In terms of the overall pot, we also know, and I'm sure you've attended scrutiny committees recently, we're all bankrupt at the same auction. There's not a lot of money around. And so it is about having to move an existing set of resources from one place to another. But of course, the trick of supporting people in the community and preventing those admissions into acute hospitals won't happen overnight. So that there is something we've got to work through in terms of how we start to shift some of those resources, and that will be based around kind of national guidance that's not yet forthcoming. So I think we recognise the problem, and I think we recognise that it's really important for us to continue to engage with you in the sector, and we're hopeful that will result in something that will be helpful to us all.
I'm going to bring in Kate and or Colin now, because part of the commissioning for this year is that we have a Sussex VCSE Leaders Alliance, and we're expecting them to work with the Neighbourhood Health Alliance, exactly that, Tom, to look at where the need is and how do we bridge the gap in terms of service delivery.
Thanks, Tanya. I mean, I think you've covered it, but just for a bit of reassurance, we absolutely recognise within the Neighbourhood Health Alliance that we need to resource the voluntary sector in particular to be able to carry out some of the work that you're doing. So it's a very live conversation, recognising the kind of limitations we've all got financially. It is something that we know that we need to address through the Neighbourhood Alliance, so we'll continue those conversations with you. I also just wanted to give a couple of really quick examples of where I think we have started to look at where we can meet the needs of working age adults. We had a really excellent case example at the place-based delivery group this week around a health hub day that had been delivered on a Saturday. Huge numbers of people attended, and the ability to kind of signpost people to services and deliver more coordinated care was really clear through that. So I think it's those types of things that we need to kind of really measure the impact of those and think about how we deliver those more regularly and across more locations.
Thank you, Tom, for that question. Very good question. And thank you for your responses. Any more questions, please? Yes, please, Ruben.
Thank you very much, Chair. My name is Robin Banerjee. I'm Pro Vice Chancellor at University of Sussex and also a Professor of Developmental Psychology. I wanted to say, first of all, thank you very much to those presenting this paper. I think it's extremely welcome and very important that we do take this approach, which is holistic, joined up, and yet also very much rooted in local needs. And I think the partnership place-based approach, I think, is really important. So thank you very much for setting it out so beautifully. One point, first of all, very broadly, is to just think about how this aligns with other initiatives and developments that are going on across the whole of Sussex. And I wanted to draw the board's attention to the fact that less than 2 months ago, we signed a civic university agreement for the whole of Sussex, which includes Brighton and Hove City Council as a signatory partner, and also the upper tier councils, East Sussex, West Sussex, and indeed with strong support from the mayoral combined county authority, and importantly for the city, also including the other university present here as well, so University of Brighton as well as University of Sussex. So very collaborative approach, and I wanted to make the point that the NHS Sussex is a critical signatory partner to this as well, and there is a strong focus on health as a core dimension of the civic university agreement, and the whole focus is on leveraging the knowledge, expertise, skills, and the person power of our university communities for the public good in collaboration with partners across the region. And I guess one of the questions that I had about this work is how much the place-based partnerships that are occurring at this quite local level within the city are connected with the broader regional aspirations across Sussex. So that's one broad question about that kind of very hyper-local to regional to national and just how we do that mapping. And then one specific question which relates to an area of particular expertise and interest for me. My professional training is as a child and adolescent psychologist, and I was intrigued to see in setting out the Neighbourhood Health Alliance ambitions, there were some quite concrete targets set in relation to A&E admissions, for example, and there's also a delivery focus which specifies in much broader way contribution to children and young people programs. And I had wondered whether in the discussion of the Neighbourhood Health Alliance there had been any focus on specific local targets in relation to children and outcomes for children and young people. So I wondered whether that work has happened or is going to be happening, whether there is an ambition around setting particular targets for children and young people in the city. So sorry, one very broad question and a specific one.
I'll start and bring partners in. Thank you for the question. I think it's a really, really important question because, again, what we want to do is to build hyperlocal that's connected to system, connected to region. And that's exactly what we've done and what we're starting. We're on a trajectory, we're on a learning journey, and obviously some of this will develop and evolve over time. So at Sussex level and Surrey and Sussex level, we have set specific expectations aligned to the national model. And as you might be aware, there are some national implementation programs and some particular pilot sites. We have one in Sussex. So a lot of the learning from the Sussex pilot in East Sussex will be feeding into that national program. And having gone to the Care Closer to Home conference and listened to Claire Fuller, who is obviously part of the national team developing the neighbourhood health, and the permanent secretary, the clear aim is to ensure that at a national level, which is why the guidance was delayed currently, is to ensure we're aligning all our incentives around the task at hand. As Ian outlined, we've got to shift care into the community. And part of that is, for example, you've heard of the Better Care Fund, and that is changing. So the whole reform around that Better Care Fund is to enable integrated care models and integrated care from hyper-local to system and national level. There is definitely that connectivity that is very apparent, but I think some of the learning will start to improve that, and that will become more visible to communities and more visible to service deliverers around the city.
Thank you, Tanya. I think I wanted to comment, I suppose, on that tension between place-based activity and Sussex-wide activity and then regional activity. I think clearly, as Tanya's indicated, this is part of a national programme. And so we are very well plugged into the sort of South East regional work and the data around that. I think what I would also want to reflect, though, and particularly here at the Health and Wellbeing Board, if you think about Sussex as a place, Brighton and Hove has a very, very different sort of population demographic to East and West Sussex. So a lot of the issues our colleagues in East and West Sussex grapple with are around frailty, around a large ageing population, around an increase in terms of mental health, around things like dementia. We're a relatively young city. I think something like 72% of our population are between 16 and 66, so we're quite young. Of course, we don't buck the national profile, but we're quite a young population. And so I think some of our sort of place-based configurations do reflect that need around a large homeless population. We have a higher prevalence of mental health need in our working age population. So there is something about a balance to be struck, I think, between the particular characteristics of place that require a certain kind of resourcing and a certain approach, but also thinking about a level of consistency. And that's a tension that I think we'll continue to work with, if that makes sense.
And just to follow up around children and young people, there is a national framework for the provision of neighbourhood health around children and young people, and the expectation is very similar to adults, is that you have these multidisciplinary teams that are able to sort of support those starting with the highest needs, so asthma, other childhood conditions, I think, in terms of finding the core cause, but obviously as an MDT or multidisciplinary team being able to manage that condition. But Kate might want to come in because part of the Commission intention is looking at adults and children, but again, it's a trajectory.
Yeah, so we've committed through the Neighbourhood Alliance to really look at children and young people and how we start to develop more of a core offer around that through this next financial year. But some of the ICTs where they're looking at their targeted offer, so that is at a very local level, have identified children and young people's needs as the one thing they want to focus on at that kind of level. So I think we've got a bit of a mixture between kind of what you've just described, Steve, actually, in terms of how do we look at what the core offer looks like across Sussex. But there is some work that's happening at a really local level that is focused on children and young people.
Thanks, Robin.
And just to follow up on that point, it's interesting that when we look at data, and I do a lot of work with a public health team in Brighton and City Council around children and young people, you do find variations within the city. And so those three areas that we were talking about before, the delivery, ICTs in East, West and Central, we can find specific patterns that map onto those. So it would be really helpful to support as best we can as a university the work that's happening at that quite local level, and I'd be really happy to do that. So thank you very much for this. It's really useful.
Okay. Thank you, Robin, for your question.
Yeah, I mean, I think it's a very good question about how the hierarchy works or how these cluster. By the way, I'm very keen on the Civic University Agreement, which, as you say, we signed, and we hope to be active partners in it. I think we are lucky. Looking for an ICB now that Surrey and Sussex, it's quite useful to look across the experiences of the two and share best practice. I think we are Fuller. You mentioned Claire Fuller. I think we are fortunate. Claire was the chief executive at Surrey, and she's doing a great job in the centre. And obviously, we're very connected still to Claire. She's the joint chief medical officer at NHS England and really leading the neighbourhood health stuff. We have taken slightly different approaches in Surrey and Sussex. So in Surrey, we focused on neighbourhoods of 50,000 people, which came out of work for citizens to identify the towns and villages that they associate with, and the council identified 29. And we've organised around those, not around district and boroughs. To get the political voice in there, we've created neighbourhood area committees, which actually have worked out pretty well, a lot better than we thought. The district and borough councils weren't keen on that approach at the start, but they've come round to it. I think another advantage we have in Surrey is that those 25 or so neighbourhood committees are commensurate, are map almost exactly onto our primary care networks. So having the GPs in that really is important because that brings it alive for the citizens because they know their GPs. And it helps the politicians, not be seen just as a talking shop, but actually involved in a community that's important. The other challenge we have in Surrey is now aligning with the unitary authorities, which is important that we do because, as I said earlier, integration with especially social care, but also obviously mental health, community, primary care is key, but we're splitting into two in Surrey, so that's proving quite difficult, but there will be hopefully a morality above that, which will allow us to integrate that and then into the one ICB. In Sussex, the 13 ICTs have been organised around the district and boroughs, so I think the challenge in Sussex is how to connect with the 50,000 neighbourhoods, which are smaller footprints, and you've got, and particularly how the PCNs are organised, how we can make them congruent and coterminous with that smaller level of neighbourhood. The unitary authorities is easier because hopefully, if it comes through, you'll have 3 unitary authorities, and I'm very pleased as well that Sussex embarked on that sort of morality of the cross-county initiative and have decided to keep that going, notwithstanding the suspension of the mayoral election or the delay of the mayoral elections. So we've got slightly different approaches in Surrey and Sussex. But I think the good news is you were ahead, I think, of many places around the country. And I think we will benefit from the learning that we can have across the two counties.
Thank you, Ian. And I don't know whether this question is relevant or can be answered, but can you tell us to what extent Brighton and Hove ICT is also aligned with our primary care or mapped into our primary care? To what degree, please?
Thank you, Councillor Baggot. Yes, I mean, in terms of Brighton and Hove, of course, we're already a unitary authority, and in terms of the configuration of our integrated community teams, we've got 6 primary care networks across the city. So each of our place-based ICTs, West, Central and East, is aligned to 2 of the PCNs. And then we have Adam from the Federation, who's very well involved in our local health and care partnership governance across the city. So I think the way that we've configured our integrated community teams, our neighbourhood mental health teams through our provider trusts, and also in our local authority configuration. So our adult assessment teams are configured in the same locality patch as our integrated community teams. And so each of those spaces, each of those places across the city is aligned to 2 of our 6 PCNs. And I don't know whether, Adam, you wanted to come in and comment on that, but it seems to be working pretty well.
Yeah, no, that was our main priority when setting up the integrated community teams, was to base it around PCNs. So yeah, we haven't done 1 PCN per neighbourhood, we've done 2.
And I think it is good to hear. The biggest challenge for us is the Wealdon, frankly, because that is one ICT and it's a rather untidy geography, but it's not Brighton and Hove, so I think we're in better shape here.
Okay. Thank you. Any more questions or comments? Yes, please.
Thank you, Chair. Thank you, partners. I suppose just a few observations, really, speaking on behalf of patients, if I can be so bold to do that. But I think we just need to make sure we explain the changes to the people. To make it a success, they need to understand what the differences are, how they're going to be seen differently, how they're going to be treated differently, what pathways they're on. I think there's been a lot of changes since COVID, and they haven't always been very well explained to patients. It's maybe more a case of just catch up. I think the GP world is one example, because although it's really good now, I think we're seeing 1 million appointments every month almost, but people don't always know who they're seeing. But that doesn't really matter. They're still getting the care they need. They just don't know that's the right person for them. So just with all this, we just need to think about how we're communicating it to the public. We need to bring them along on the journey. And I think as a board, we need to be thinking about what differences it's actually making to people on a day-to-day basis. And I think it'd be really useful for the board to actually have some case studies brought back to it, where we can look at how things have changed, the pathway someone's been on, how they've been integrated, how their care's been integrated, how they've been supported, and how it would have looked like, to give us a sense of how things are changing. Because I think it's really hard sometimes to hear this and then actually see it in reality. So I think that would be really useful. We have a very transient population. People move around. So I think one of the challenges for us is we need to be flexible when we're building around local populations. And it's right that we use population data, but that's going to change over time. I'm not suggesting populations change dramatically, but we have a lot of young people, they come and go, things may change. So how do we flex our models to make sure that we can respond to changes in population? And so the last thing I wanted to just mention is that in terms of engagement approach as we go forward, I think we just need to bear in mind we need to have some sort of standardised approach to where there's a coordinated way of doing things as well, so we don't see duplication of effort, engaging people, getting their views on services. And so we share and learn, not so that one area is doing something one way and the area is doing a different way. We just need to have that coordinated approach, because we're quite a small city, and I think there's a lot we can learn from between the 3 different areas. They're not just distinct areas, there's a huge amount of overlap. So there's just some reflections for me on this. Well, just to say one last thing is, I think we are already seeing change. I think the East Brighton Hub, just as an example, that is delivering change. People are seeing differences. People are being supported in their communities. and projects at the hospital. It's the care navigation hub, I think, that's already, I think, supported or redirected over 700 people away from ED just through the work they're doing. So those people are going to the right place at the right time rather than going to ED. So change is happening. People may not necessarily feel it, but it is. I think we just need to remember and also bring back to the board the difference we are bringing, and I think that's really important to reflect upon. Thank you.
Thank you. Yeah. Any more comments, questions? All right. Does the board agree to note this report? Okay. So we go to the next item 40, Better Care Fund, March 2026. I would like to invite Chas Walker to present the report, please.
Evening, everybody. I'm Chas Walker. I'm the Joint Programme Director for the City's Health and Care Partnership. Part of my role is to support partners in the delivery of our BCF plan. So I'll be leading on reporting on the paper that. So I'll just cover the paper that was included in the pack. So as discussed earlier, the Better Care Fund is one of the statutory responsibilities of the Health and Wellbeing Board. So the paper sets out asking the board to note performance against our plan for Q3, and then also the paper covers the summary of the new planning guidance for next year's Better Care Fund 26-27 that was released a couple of weeks ago. So just in terms of our metric performance over Q3, we included some graphs this time in the report. I hope they're sort of helpful. They give you a sort of a view over the last 24 months in terms of our performance. So the first metric is our emergency admissions performance. So we remain off track on that metric for this year. So the graph demonstrates, so the sort of orange line is our planned performance metric targets for each month, and then the blue and the green are our actual performance local, and then that sort of validated data is the blue one that's then validated. So I think it's really important when we look at this metric. At the last Health and Wellbeing Board, we sort of confirmed with you the requirement that we were needed to further stretch our targets for the final Q3 and Q4 of this year. So you can see the orange line is lower in those last few months of this year. So that's added an additional pressure in terms of the metric target to meet that stretch target in Q3 and Q4. We had early onset, as we all know, of sort of winter this year, so we can certainly see in December increase in admissions that was sort of attributable to some of the pressures that our acute system in the winter. So in terms of how we're trying to mitigate that, in the last report around neighbourhood health, there's that NHS Sussex commissioning intention around 10% reduction in avoidable admissions, the establishment of the highest and ongoing needs programme, and the multidisciplinary teams that have been set up this winter. So that's a key focus in being able to identify people in our community who are likely to end up in a hospital system and put community into integrated and proactive community intervention to prevent those admissions. So that's where a lot of the focus is in trying to improve our performance in that area. Our next metric is our discharge delay performance. So again, I hope the graphs were helpful. Again, just giving you the sort of trends. Exactly the same challenge that Q3 and Q4 this year. We had to stretch our targets, which has exacerbated some of the sort of difference between our actual performance and those metric targets. So at the last board meeting, we did spend quite a bit of time discussing the work around our local discharge transformation programme. Steve's already covered in the neighbourhood health, a lot of the work we're doing around transformation of care hub in the hospital, and those things are starting to show improvements, but again, it takes time for those to work through into those actual figures, and there is obviously the sort of pressures that our hospital system are experiencing. So, and then our third metrics target, we haven't got a graph for that, is our residential admissions into residential care and nursing placements. So that one we are on track on, and local authorities seeing improved performance in terms of reducing the number of people in our communities that need residential and nursing care. So we're better supporting them to remain independent in the community. Steve, I don't know if you wanted to just give anything more on some of those figures. So.
Thank you, Chaz. Yes, in terms of our permanent admissions into residential and nursing care, so I think in the report, the target was about 248 admissions a year. So far this year, across adult social care, for our over 65s, we've had 183 admissions into long-term residential or nursing care this year, so significant improvement on last year, and an improvement on the stretch target that was agreed through the BCF this year as well. So good news in terms of our residential admissions. For our working age admissions into residential care, a lot of the way that we report data has been changing. We're now moving into a system where we're reporting directly into the Department of Health and Social Care on a thing called client-level data. And I think over the past few years, we had been very transparent as a local authority and included all of our working age admissions, which in terms of our national performance did us a slight disservice. So for those people who go into residential nursing care from coming out of a mental health hospital under Section 117, we had included that in the totality of our reporting, which made our performance look rather poor. We've now got clarity from the DHSC around that reporting, and again, so far this year, for our working age admissions, we are 36 nationally around our performance of residential admissions, giving us a performance of 22 admissions this year. So I think our performance around hospital discharge remains a challenge, as it does across the whole of Sussex, but we're pleased to see some significant improvements in our performance around residential and nursing admissions.
Thanks, Steve. And obviously, when we look at the Better Care Fund plan and its investments, there's the minimum investment into social care and the local authority Better Care Fund, which goes into supporting that performance, as Steve's described. So the next section of our Q3 report just sort of sets out where we are in terms of our expenditure. So we set out a plan for the year, a budget, and then it's broken down into the categories, the sources of funding, so disabled facilities grant, the NHS minimum contribution, local authority Better Care Fund, and then the additional contributions that are made out by partners outside of the sort of Better Care Fund grant. So in terms of where we are at Q3, we can confirm that actually we're on track in terms of our spend. It is roughly about 75% of the funds can be accounted for at the end of Q3. So there was a bit in the report around our community equipment service. We talked about that at the last meeting, and the need to change our provider at quite short notice. So there was provision for if that created additional costs. So we're still working that through, but I think actually the level of additional costs is not going to be as great as we first feared when that situation arose. So, and then just moving on. So that's the element of the report, which is just looking at the key requirements in terms of the monitoring of this year's plan. I was just going to do a quick sort of run through in terms of giving the board kind of a summary of what the planning framework entails for 26-27. So again, there's been very clear when the planning framework was published that the Better Care Fund this year, 26-27, marks a sort of the first year of a wide reform of the Better Care Fund to align with neighbourhood health, and I think that's really important that we're sort of cognizant of the fact that the Better Care Fund will be a key element for supporting development of neighbourhood health and the Health Wellbeing Board's responsibility around neighbourhood health. So the Better Care Fund will remain continued to focus on ICBs and local authorities joint planning to deliver a more integrated preventative and preventive care services, but there's a real focus on people with complex needs in the planning guidance this year, so which again fits with the neighbourhood health sort of guidance that's coming through. So there's also a heightened expectation that the BCF will support as be a practical lever for neighbourhood health, and that within the planning guidance there's specific references around the BCF's role in supporting intermediate care and reablement comes through really clearly in the planning guidance. So what is recognised is that the planning guidance only came out in February. We obviously have contracts with a number of providers that need time if we're going to be doing that sort of level of transition. So it's also expected that there won't be any sort of change that would then jeopardise those existing services that are funded through the BCF. So this is very much transitional year sort of thing, looking at how existing investment supports neighbourhood health and looking to plan for further years, as we know that reform agenda will continue to progress. So, and also there's very clear narrative around that continuing support for adult social care within the planning guidance. So then just in terms of the sort of financial envelope, so our Better Care Fund plan, or Better Care Fund this year is 42,689,000, so we're seeing a 1.9% growth for next year, so 43,528,000. So that increase, so the highest level of increase is to support adult social care through the minimum contribution to adult social care. That's seeing a 4.4% growth in terms of that element of the Better Care Fund grant. Then the discharge and wider NHS minimum contribution, 2.1%. The local authority Better Care Funds and Disabled Facilities grant, which is sort of integrated into the wider local government settlement at a 0%. The Disabled Facility grant, that's why there's a couple of asterisks, is there. That's under consultation at the moment around the fairer funding formula for local government, and so they're consulting on how the formula is worked out for local government around the Disabled Facilities grant. So obviously the consultation's just closed, so we're not clear what the final result of that consultation, so we're planning on it being the same value as last year at the moment. So we will keep the board up to date once we understand the results of that consultation. So, and then just in terms of the sort of key planning requirements that we will need to note as a board and be responding to over the next couple of months. So, so local authorities, will need to continue to agree a joint plan. So a lot of the goals remain the same as they have been this year. So the plan should focus on reducing emergency admissions for people over 65, target reducing delayed discharges against homes this year, and reduction in demand for long-term residential nursing care placements. There is a greater emphasis in terms of the narrative plan and the targets we'll need to develop locally around improvements in reablement outcomes and intermediate care. And there's an expectation that the BCF plan will align with wider strategies, so around strategic commissioning. So we talked about the 10% board and the strategic commissioning that the ICB have done, the commissioning intentions. So plans will need to align with those strategic commissioning intentions and with the sort of local and sort of system-wide sort of neighbourhood health plans. So we'll need to take those into consideration in developing our BCF plan for 26-27. The submission date for plans is 19th of May. So we have a sort of number of health and care groups that will work on developing that plan. It will need both local authority and ICB CEO sign off and Health and Wellbeing Board Chair sign off. Our next board meetings until July, so we'll submit a draft plan signed off by those executive leads that will then come back to our meeting in July for final sign off. So and then Section 75 agreement that supports the pooled budget will then, as in previous years, once the plan's been agreed by the Health and Wellbeing Board in July, will then be required to be signed off in September. So they're the sort of key timescales that we're working to.
Okay. Thank you. Thank you for your report. Yes,
I think I'm actually involved in the planning for next year, for 27-28. It always worries me when the NHS changes an acronym, which they sort of mistake for an improvement in performance. So renaming it the Integrated Care Funding Framework does worry me. However, I think if we can land it, I think it will have some important changes along the lines that you're already doing, actually, but also that will become more important. It will stress pooling and integration and outcomes more, but I think you do that pretty well here. We do it very poorly in Surrey, so we don't pool the funding. Pooling is pretty poor, and we don't have any measured outcomes in terms of discharges or attendances, so I think you're ahead of the game on Surrey on that, but it'll tighten up, I think, and we can talk about more about this offline, as the ICFF comes in 27-28. As you say, neighbourhood health will be a key part of this because to date, take just one element, delayed discharge pathway has to be set in the context of the patient's broader pathway, which is in the neighbourhood and high-risk care management. Probably there'll be more emphasis on partnership with the independent sector. The independent sector feels pretty badly used currently by the NHS and social care. So we're talking about longer contracts, outcome-based contracts, a proper balance of risk, so that the independent sector delivers more reablement in scale-efficient units, either domiciliary care or in nursing homes. So I think it's generally, a good transition. Obviously, the amount of funding is under a lot of stress. So we are trying to defend that. But as I say, let's talk about this offline. Mark Stainton's been quite helpful, actually, in inputting into that process. So it'd be good, Steve, if we could talk to you about this as well.
Thank you. Any more comments or questions? Right. Okay. Does the board agree to note this report? Let me check. I think we are having a break now. We're going to have a break for 15 minutes, and then we'll be back here at 6 o'clock. The last item on the agenda is NHS Sussex Integrated Care Board update. I would like to invite Tanya Brown-Griffith to present the update, please.
Thank you, Chair. And as I was walking by, one of my esteemed colleagues gave me 30 seconds. But I shan't be 30 seconds. I shall give you an update. Since I did not send you a paper, and this is a verbal update, obviously following the last update, which has come to each of the last 3 boards as a standing item. I think what has changed since the last update is that we now have our executives and non-executives in place for the new Surrey and Sussex ICB partnership, and then there will be one organisation from the 1st of April. I've got Ian here as our chair, who will obviously add any more context to the updates. So in terms of the last update, we spoke to the board about the potential launch of the consultation. That has been launched since the last update came to the board, and the structure consultation ends on the 11th of March even. We have also recently launched what is now replaced the 2P process, which is a Cabinet Office Statement of Practice. Again, as Ian said, if we didn't need any more abbreviations in the national and NHS, it's COSOP for shortened, and that involves the transfer of staff from the current organisations, 2 different organisations, into the one single organisation. Again, as I mentioned, from the 1st of April, that will be the new NHS Surrey and Sussex ICB. Recognising, as I said at the last board, that we had just launched a MARS process, which is a mutually agreed resignation scheme, because one of the requirements of the change in terms of the ICB a new model, and the model for the model for the region is that we needed to reduce our administrative function of the ICB by 50% and more for some areas. So that really involved ensuring that we have a good process for transitioning staff who are obviously currently working for the 2 different organisations into the new organisation. We have released a new structure. We've shared that structure with partners. We've also shared the consultation document with partners. We've shared with partners our new ways of working, so several documents. I'm sorry to fill your inboxes. I'm sure you all had 6 different documents going through, especially our provider partners and our local authority partners would have received all of those consultation documents for awareness, comment and feedback, because this is a true consultation period, and obviously we want to ensure that we're hearing not just from staff who are affected and impacted, but our providers, partners, stakeholders who obviously will also be impacted. So as I mentioned, that concludes on the 11th of March, after which we will have a new structure and we'll go through a process of filling posts into that new structure. We're hoping that by the end of June, we will have filled the majority of those posts, and obviously will start to function fully. Not that we won't function from the 1st of April, and not that we're functioning now, but we'll function fully with the new structure and the new staff in place at that point. We're obviously continuing to deliver our services, so I think there's an element of fair that we won't be delivering services and we won't be commissioning or continuing many of the work we're doing. The areas that the model ICB national ask that we step away from are areas that we will be obviously reducing over time, and some will be stopped significantly. Some of those areas will also be transferred from the ICB into other areas, including the new formation of the NHS function, NHS England function, as the shift obviously to Department of Health and Social Care. And Ian can obviously talk a little bit more about the work that's happening there. In terms of another update that I gave last time was around where we were with system planning. And I think by now we have, as I stated earlier, published our commission intentions, sent out our commission intentions letter, which we were not at this stage last board. We have also completed our medium-term plan for NHS England, and that covers the financial year 2026, which is the start, and up to 28-29. So what you will see We have shifted from annual planning cycles to a rolling 5-year planning cycle. And as mentioned before, that will support our new role as strategic commissioners, moving away from an annual year-by-year planning into more of a strategic change and that long-term focus and long-term view. The last thing I probably will touch on is that we have, alongside that medium-term plan, we've also been working across Surrey and Sussex in our joint medium-term plan and the longer view in terms of key priorities set against the 10-year plan. And we submitted that plan on time for the February national deadline. We have also, since last board, received the National Strategic Commissioning Framework, and we have across Surrey and Sussex completed our needs assessment of our population, so we know where those population needs are. We're obviously in the process of, and Ian can update us in terms of where we are with our new sort of launch of our new strategy for the joint ICB, aligned again to the 10-year plan. And lastly, I think in terms of in the Model ICB blueprint and in the 10-year health plan, the framework also recognizes the growing role for provision in strategic commissioning and encourages us as an ICB to provide, to support providers in developing their commissioning and integrated capabilities. And we see an evidence of that today with the Neighbourhood Health Alliance, who have received delegated functions from the ICB to provide and commission on behalf of the ICB what's required for neighbourhood health for 26-27. So that's the sort of shift nationally in terms of model ICB and model region. I'll hand over to Ian, who may want to.
Thanks, Sonia. I think it's a good summary. I mean, just to add or amplify a couple of points. It is a tough time. Clearly, we're laying off 60% of our workforce, 1,200 people. 60% of that is going. So you can imagine what morale is like in the ICB. We're doing the consultation, as Tanya said, and we're not really going to be, completely up and running, as Tanya said, until May, June. So we're getting on with stuff in the meantime, but you can imagine it's not that easy. However, I am optimistic, actually, because of the things we've talked about today, the neighbourhood health, the left shift. I think we're in a good place compared to many other parts of the country in Surrey and Sussex. And I think we have to raise the ambition. As Tanya said, we've done the commissioning intentions. We now need to turn that into a delivery plan with clear outputs, with clear impact. So we reduce attendances, we reduce delayed discharges, we reduce pressure on GP practices, ambulance call outs. We really need to make this hit the ground running, not another, what I've discovered is too often an NHS wish list that we will do this, we will do that, we will do everything. And actually we look back and we didn't actually do it. This time we have to make it happen. So I am optimistic. I think the merge has gone well in terms of getting Surrey and Sussex together. It is a tough time, but I think we are probably the best placed ICB in the country to deliver on this, and I feel we've got a huge obligation as a result of that to actually be a leader in the country and have that ambition. And the Health and Wellbeing Board, I think, is a key part in the plan to make a real change for our patients and residents. So, thank you.
Any comments? Any questions? All right, then I would like to invite everybody to, does that board agree to note the report?
Yeah.
So thank you very much, everybody, for attending. And I'll call this meeting to a close.
Yeah.
Thank you, John.